is Andreas Mitchell. I'm a fourth-year student in medicine and public policy, so I'm actually at the Kennedy School this year getting a master's in public policy. And I'm here in my role right now as co-chair of the Center for Primary Care Student Leadership Committee here at Harvard. We're also co-hosting this event with the Student Coalition on Addiction and SIFMA-Now.
This has been described as one of the most well-researched public health interventions in Canada. So I'll just go through some of the key findings. The downtown east side has a lot of alleys where a lot of people were injecting in open spaces and in doorways in these alcoves and in very unsanitary conditions. So people would use rainwater to inject in. There was a lot of syringe sharing, which perpetuated a lot of Hep C and HIV transmission. And a lot of overdoses that would occur in these alleyways made it very difficult for people to intervene and prevent overdose death. So a lot of New England cities are now at the level of overdose burden that they saw at the peak in the Vancouver crisis. And HIV was about 19% per 100 person years in a cohort of people who inject drugs. That's actually the highest that's ever been observed in a North American setting. So those public health crises were really what first spurred the interest in a different kind of drug policy and a different kind of approach focused on harm reduction. In 1996, the Vancouver Area Network of Drug Users started, which advocated very strongly for their own rights, their own protections, and a lot of public health interventions, which we now see today, like the Supervised Injection Facility. So they led a lot of protests at City Hall in the late 90s and early 2000s. Other groups came together as well. This was an organization called From Grief to Action, which was a coalition of fairly wealthy, well-to-do mothers and fathers who had lost sons and daughters to overdose. They started really advocating politicians to do something about this crisis. And in 2000, the City of Vancouver released a new drug policy approach, which was called the Four Pillars, where harm reduction was a specific pillar of drug policy moving forward. And part of harm reduction was expanded syringe exchange access and also eventually the supervised injection facility. So what are supervised injection facilities? They are places where people inject pre-obtained illegal drugs. So people come into the facility with their illegal drugs in hand and they use those drugs under medical supervision, usually nurses. The important thing is that these are not simply places where people inject and leave. They're meant to be wraparound services. So in the Vancouver setting, a major goal of Insite is to provide access to medical care. Insite is a pathway and a referral into these services. And internationally, there's about 65, maybe more, up to 100 now, this point is old, SIFs around the world, primarily in Europe, also one in Australia. There's actually a second one in Vancouver as well, which is in a day center for HIV positive people. It's a private facility, so only people who are clients of that day service and residential facility can use it. It's only 2 booths, it's quite small. Much like in the US, the control of illegal substances is federal purview in Canada under the Canadian Drugs and Substances Act. So Insite was opened in 2003 with an exemption which was provided under what was called Section 56. So this was an exemption that allowed people to hold or be in the premises of illegal drugs without persecution for drug possession and so on. The goal of this exemption was primarily for medical and research purposes, but there was a line in there that says also at the discretion of the Minister of Health for the greater good of the public. So there was really 3 aims of Insite. The first was really a public disorder aim. As I mentioned, there was a lot of discarded injection-related paraphernalia, a lot of public injecting, and so the goal of Insite was to bring folks indoors, bring people who are injecting on the street inside, and reduce the discarded syringes in public spaces. The second was public health focused, reduce overdose and infectious disease risk, prevent hepatitis C and HIV transmission. And the third, as I mentioned, was to improve access to health care for people who are very marginalized and experience a lot of barriers accessing health care. So in Insite, there's a lot of services. They do a lot of wound care, a lot of basic health care is provided. There are addiction counselors on site, there's peer counselors on site, a lot of mental health services are provided, and a lot of referrals to other services as well. And it's an anonymous service. People will have a handle, a client username. They provide basic information about what they're injecting, and that just is for surveillance more than anything else. Then people go into what's called the injecting room, which is shown here. There are 12 booths where people can inject at, and the nurse's station is behind. They also provide basic injecting material, so this is a standard kit that's provided when someone enters Insite. You can see here we've got a sterile syringe and needle, some water, cookers, tourniquet, matches, and so on, and also swabs for cleaning the injection site as well. They provide injecting education as well, so nurses can talk about best injecting practices. They cannot inject people themselves, so people need to be able to inject on their own to use the service. So that's something to note. Once people are finished injecting, they move kind of around here to what's called the chill-out room. So this is where coffee is provided, snacks, peer counselors, clinicians, psychiatrists, and other wraparound services are really provided after people inject. People can chill out there for really as long as they'd like, unless it gets very full, before leaving the facility. Now, this is on the first floor of the facility. On the second floor is a detox unit called Insite. So people can actually be referred directly from the supervised injection facility to a detox on the second floor, and then to other residential or outpatient facilities. So we'll look at the evidence that actually shows that use of the SIF has resulted in increased uptake of addiction treatment. So unlike a lot of preconceptions around sort of perpetuating or increasing drug use, in fact, the service access operates as an access to a lot of treatment services. There are over 700 visits a day, if you can believe it. So the throughput is very, very high. Not everyone injects. They also just operate as a standard syringe access program, so people can come and get syringes and leave. Condoms are provided as well, a lot of other harm reduction material. So you don't have to inject to use the facility. There's been 3.4 million injections since it opened in 2003. Not one death ever. So that shows you how preventable overdose fatality really is, when you can have millions of injections and not a death. So there's never been a fatality. There are other events that happen. Overdose often can be managed just with oxygen or naloxone, but they will call in an ambulance if there's a more severe issue. So they will rely on other sort of medical services in those events. It's very low threshold. There's not bulletproof glass. It is Vancouver, and there's a lot less gun violence in Canada in general. But it's not a lot of security. The nurses are open, and they rarely have incidents. Maybe some fights or some aggression, but it's very, very rare and managed usually by the nurses very well. It's open now 20 hours a day. They are considering opening more facilities. It really operates at capacity, and so there is still some outdoor injecting because of wait lists. Sometimes people will wait up to an hour to use the facility. So we were able to compare rates of entry into treatment, people that use the facility versus people that don't. It increases by about by about twofold increased uptake of addiction treatment. So it's really a positive benefit. You cannot have a successful SIF without the support of local police. Police could stand right outside this service and arrest people as they're coming in. The exemption covers the inside of the facility itself from the federal drug laws. The Downtown Eastside Business Association was originally opposed, and then they really liked how it basically cleaned up the neighborhood. There was less public injection drug use, less discarded syringes, and so they now fully support the facility, as do the police. When you implement an SIF, the Vancouver Police Department's official policy now is if someone is injecting outdoors, they escort them to the facility. So the police actually play that role often in Vancouver. So at Insite, they are actually piloting a project where people would drop a little bit of their drug in water, dissolve it, put these rapid tests in, and it will show you whether there is fentanyl contamination in the drugs. They just started that, and so they're kind of seeing how that goes. This was a huge evaluation. There was a lot of data being fed into our evaluation, so we'll kind of go through it in the 5 data sources we had. The first was the SIF database. So as I mentioned, it's an anonymous service. People come in, but they have a consistent handle that they use, and they report basic things like what they're injecting, and so that database can be used for general surveillance. As I mentioned, also in that database is how the nurses respond to an overdose and so on. COZ was a cohort of clients of the SIF. So once it opened, We randomly sampled, so when people went into the facility, there was a random number generator. People would be randomly sampled to participate in a research study. We had about 1,000 people enrolled in the COZ cohort. What was really exciting and made the evaluation very robust is the Vancouver Injection Drug User Study, or VIDUS, had been going on since 1996. It's a long-running study of people who inject drugs. And so that was present before Insite opened and allowed us to conduct a lot of comparative studies to examine what were the differences in people who used the facility versus people who didn't, things like that. So that was a very rich data source that we used. CHASE was an administrative data set. It allowed us to link to addiction treatment centers in Vancouver, so I'll show you that. And then a lot of other activities that I wasn't working with, other ethnographic interviews, in-depth qualitative interviews, community stakeholder interviews, police interviews, and so on. I won't talk about that today. So the two cohorts that I worked on predominantly, again, VIDUS was long-standing from 1996 onwards of over 1,500 people who inject drugs. They complete surveys every 6 months on a bunch of things. It takes about 3 hours to conduct this survey. It's intense, and a very good follow-up rate. COZs started when the facility opened and was a random sample of clients. So the first question we wanted to ask, right, like, is the SIF reaching the target population? You want to have people who are at risk of overdose and HIV transmission use the facility, and so that's what we wanted to know. 3.4 million visits, isn't that amazing, in over a decade of use. Over 18,000 individuals have registered for the facility. The majority of people who use the facility live in the neighborhood. Some people do use the facility if they have a new dealer, for example, or they're using a drug that they haven't used in a while. They'll go into the facility, use it, and then maybe go elsewhere and use elsewhere. Many people do use the facility daily or more frequently. As I mentioned, about 700 visits a day. The majority of people are injecting, but you don't have to inject. In 2015, there were 768 overdose incidents. This has really gone up with fentanyl. It used to be around 1 overdose a day. Now they're seeing 1 or 2 overdoses a day. 5,000 clinical treatment interventions. So this would include wound care or other referrals to health services. This kind of gets to one of the earlier questions. 5,000 referrals to health and social services, predominantly addiction treatment programs. So pretty solid, uptake of these health services among clients of the SIF. And 400 referrals to on-site directly upstairs. So that's the link detox, a lot more referrals to other detox centers in the city of Vancouver. The majority of people are pretty long-term users. The median age is around 39. The majority are male. And 20% are Aboriginal. This would include First Nations, like Native American. Inuit or Métis is another category of Aboriginal people in Canada. And predominantly heroin is used. Methamphetamine, I was surprised. This was more popular than I thought. I just pulled from the website, and about 10% using cocaine. So people are using a mix of drugs there. Prescription opioid injection has never been that common in Vancouver. The heroin market is really vibrant, and so it's predominantly heroin injection, with increasingly fentanyl cut in. We had this existing cohort of people who were injecting who actually went on to use the facility. So we were able to look at that using VIDUS. And this is what we found. So this is looking at factors that predicted use of the facility. So this is an odds ratio. If it's positive, it means it was positively associated with use of the facility. You can see here we're reaching the people that we wanted to reach. Public drug use was a huge marker for using the facility. So people who were injecting in public, much more likely to use the facility. People who are homeless, people who are injecting daily, and also people who had recently overdosed, which was really critical. A main risk factor for an overdose is a prior overdose, right? So you want people who have overdose history to be using the facility, and indeed that was the case. So this was really positive findings for us. When the facility opened, there was a lot of concern that it would lead to what was called a honeypot effect. So the police and the business owners were worried that a lot of injectors from all over the city would descend on the downtown east side and cause even more sort of public disorder and crime than was currently in the neighborhood. So Evan, actually, who is my other supervisor, had this really nice design. This was before my time, but basically what they did is, in the 6 weeks before the facility opened and the 12 weeks afterwards, they had research assistants walk around the downtown east side and basically count the number of discarded syringes and people they saw injecting in public, and just counted those to see what happened once the facility opened. And this is what you can see here. Public injection drug use, number of injectors that they observed. The dashed line represents when the facility opened, you can see going down, and the amount of publicly discarded syringes in the neighborhood also going down. They built fancy models, which I won't burden you with, but they did build models that accounted for rainfall, police presence, and a lot of other potential explanations for public disorder, and the effect of opening the facility was still significant. So we really did not see that honeypot effect. If anything, it's very effective intervention for reducing public injection drug use and public discarding of syringes. So another question we wanted to ask was, is the SIF reducing risk behavior, predominantly syringe sharing, among clients? So this was done by my supervisor, Thomas. This was published in the Lancet in 2005. And again, this study used VIDUS, so basically, we were able to compare people who chose to use the facility versus those that didn't. And this just looks at factors associated with syringe sharing. So at that point, about 11% of people in VIDUS reported syringe sharing at least once in the last 6 months. So we looked at what predicted syringe sharing. So you can see here, needing help injecting was very much positively associated with syringe sharing. But use of the safer injection facility, opposite, 70% less chance of syringe sharing if you were using the supervised injection facility. And this was any sharing, right? So syringe sharing is not permitted in the facility itself, but even among people who are using the facility, just in general, they might not use it for all of their injections, they're more or less likely to report syringe sharing in general. So preventing HIV transmission there. Can the SIF be a pathway for people into treatment and eventually lifelong recovery? This is a really nice study design. It was published in the New England Journal in 2006 by Evan. And we used basically that administrative data set I talked about. So they linked SIF clients with a big database called Chase that records all of the addiction treatment admissions in the city of Vancouver. So they were able to see, okay, among clients who use the SIF, what is the likelihood that they enter any addiction treatment, not just the detox right upstairs, but any addiction treatment in the whole city. And what they found was the following. So these are hazard ratios. They look at time to entry into addiction treatment. And again, if the number is positive here, you want to look at this row. If the number is positive, that means it's promoting entry into addiction treatment. So a couple factors predicting entry into treatment. Ever being in treatment, 2.43. So again, lifetime history of treatment, predicting entry into treatment. What's important really is that weekly use of the SIF was associated with a 72% increased likelihood of entering treatment during the study period. Also, independently, seeing an addictions counselor in the facility, this should really say addictions counselor at Insite, also associated with a twofold increase of entry into treatment. So just using the facility in general promotes entry into treatment. If you can have addictions counselors and clinicians or peer recovery coaches working in the facility, that's even more effective in terms of providing a pathway for people to enter into treatments. I do know that Onsite, the directly above Insite, has a very high rate of treatment detox completion, around 60%, which is pretty good in terms of the detox facilities in Vancouver, because it's really a model facility, right? And so the detox services offered are very good compared to other facilities in Vancouver. So this was published in the Lancet in 2011. We spent a lot of time trying to figure out how can we show an effect of Insite on overdose mortality. The problem is, from an epidemiologic point of view, as I showed you earlier, people that use the facility are at higher risk for overdose. So if you compare people that use the facility with those that don't, you're going to get this spurious finding that Insite maybe promotes overdose, and it's because what's called a selection bias. People who are using the facility are likely to be at risk for overdose. And we can't do an RCT, we can't randomize people to use it or not. So in around 2009, MJ and I started to work with the medical examiner in Vancouver, and they wanted us to analyze some of the overdose mortality data. So that was a separate project that he and I were working on. We had access to all of the case reports of the overdose mortality files, including the exact location where overdose occurred. In the city of Vancouver, actually the whole province. And so he and I realized with this data set, we could actually start to look geographically at the overdose patterns before and after Insite opened in the community broadly, just to see could we pick up a community level effect of opening the facility on overdose mortality. So that's what we did. Basically, we took all of the deaths that were due to overdose in the city of Vancouver over a certain time period. We went way back between 2001 and 2005 was the data we had access to. September 2003 was when the facility opened. So 18 months before and 18 months after the facility opened. We looked at all deaths caused by an illicit drug overdose, and then we used some other data sources as well to rule out some possible confounding. So he and I, this was very painstaking, this took us months. We geocoded the exact location of all of the deaths. There were 900 in the data set in total. Using 6-digit postal codes, which in Canada are about sort of half of a city block, so more precise than a zip code. We used ArcGIS to code all of those. And we wanted to look specifically at the area within 500 meters of Insite. So a fairly small area within the facility. Again, the vast majority of users are in the downtown east side, and this radius really captures that neighborhood. As a quasi-control, we looked at the rest of the city of Vancouver. And the hypothesis was the overdose rate around the SIF should decrease more than the rest of the city of Vancouver because most people who are using it live in that neighborhood. So that's what we did. We looked at the difference in overdose fatality rates before and after the facility opened in those two geographic areas. This was what we came up with. So this is a map of the city of Vancouver. The green shows the population densities. So we were able to look block by block at population density, and the red dots show you a location of a fatal overdose. You can see here the downtown east side at the top of the map, the SIF shown in yellow. So the SIF located right in the middle of where the majority of overdoses occur in the downtown east side, that area there. So out of the 900 we had to code, 290 were in the city itself, the rest were in the suburbs and other areas we were interested in. Most of the overdose fatalities were men, which is what we typically see. The median age was 40. 1/3 of the overdoses occurred within 500 meters of the SIF. So that shows you the overdose burden in that neighborhood is really tremendous, very, very large. Overall, the crude overdose mortality rate in the city was 10 per 100,000. Again, what we're seeing now in Rhode Island, Woonsocket, Providence, Warren, overdose rates 45 per 100,000. So that just gives you an idea of the magnitude. We have an intense overdose crisis in Rhode Island and in much of New England. So these are the results. So this is within 500 meters of the facility. This is more than 500 meters away in the rest of the city of Vancouver. The number of overdoses in each of those areas before and after the facility opened in each geographic area. And the person years at risk. We got this from the census. This is just summing up the population size of all of the city blocks in each of those areas over the 18-month period. And these are the overdose rates. So you can see 254 per 100,000. Again, huge overdose fatality rates around the SIF before and after. That is a 35% reduction, which is statistically significant. In the rest of the city, just a 9% reduction, no effect overall. So we concluded that the SIF was likely having a positive effect on reducing overdose mortality above and beyond what the overall trend was in the city of Vancouver. This is what it looked like at a block-by-block level. So the colors here shows you the overdose rate per city block. The Insite is shown in the star in red. The 500 meter radius are all of the colored blocks. So you can see before the facility opened, a lot of high levels of overdose mortality. After the facility opened, you can see in most city blocks, overdose mortality rates went down. When you submit something to the Lancet, you get a lot of critiques and a lot of comments that you have to address. And so You have in spatial analyses what's called an area unit problem. The size of the unit you choose can really affect your results. We chose to look at things at a city block level. The reviewers were like, what if that's just a function of the fact that you chose these very small units to look at? So this was, I think, this is my favorite part of the paper. I love this. When MJ and I figured this out one day. We looked at census tracts, which are larger and they include more city blocks. And we looked at the overdose rate difference. So before and after the facility opened. So this is the overdose rate before minus after. So if the value is positive, that means the overdose rate went down in that census tract after the facility opened. You can see here, and then what we did is we plotted the census tracts based on the distance from the SIF to the centroid of those census tracts. And what you can see is that the two census tracts that are closest to the facility had the largest reductions in overdose mortality. The rest of the city really just random noise. Okay? And that line, which is a nonlinear regression, explains 67% of the variance. So 60% of the variance in the change in the overdose rate was simply due to the distance from the facility. So I think this is really compelling. It really shows you that the facility is having an impact on overdose mortality, really right in the neighborhood where it's located. And of course, limitations. We were unable to look at confounding, changes in drug supply or purity, scale up of other interventions, and changing community drug use patterns. So it is fundamentally an type of ecologic study, so do take these with a grain of salt. It's got a lot of news. It got written up in the Globe and Mail, which is sort of the New York Times of Canada, which was great. A lot of editorials promoting the findings, and a write-up in Science, which was really awesome as well. We were going along, publishing a lot of peer-reviewed studies, and we started to get pushback. And one day, Thomas and I woke up. This was in 2007. I was a master's student back then, so this was before the Lancet study came out. And he had got an email that said, hey, have you ever heard of the Journal of Global Drug Policy and Practice? And we're like, no, that's weird. We don't know that journal. We looked. This was volume 1, issue 1. This guy from the Drug Prevention Network published a critique. So this is basically a faux peer-reviewed journal. It was basically an online blog that this institute had turned into something that looked like a peer-reviewed journal. And this guy published what was apparently a peer-reviewed study critiquing a lot of our findings. When you looked really carefully at the website, you actually saw that it was funded by the Drug Free America Foundation, which is, the explicit goal was to vigorously oppose policies based on the concept of harm reduction. This was the former Conservative Prime Minister of Canada, Stephen Harper, and the Health Minister. They grabbed onto these findings and used them to create in the public discourse this fake scientific debate, right? So this was a quote from the Premier. There has been more research, and some of it has been questioning the research that has already taken place and questioning methodology associated with Insite. There is clearly a public debate going on, and clearly there is an academic debate going on. And the Minister of Health said at the time, I think it's quite clear from my remarks, that there exists today a significant degree of uncertainty in the research. I believe that priority must be focused on treatment as prevention. I can inform you that the Minister of Justice will be appealing the decision, which was at that point before the Supreme Court. So again, an example how a lot of these advocacy organizations promote fake debate in science, and politicians can grab onto these to support their points of views. Luckily, we had a lot of amazing support in the community. I just love these photos. You know, you see people with protest signs that say, trust the evidence, Insite saves lives. So at this point, we had a population of people who are willing to really promote science and evidence, and that was very critical, I think, in turning public opinion. The Premier and the Prime Minister, Stephen Harper, took the facility to court. It went all the way up to the Supreme Court of Canada. They tried to close the facility, basically revoked that Section 56 exemption. The Supreme Court of Canada heard arguments from users themselves. Dean Wilson was a user of Insite. He went before the Supreme Court of Canada, and this was their final decision. The dual purposes of the Canadian Drug Substances Act is public health and public safety. Provide some guidance for the Minister of Health, where the Minister is considering an application for an exemption from this act for a supervised injection facility. he or she should aim to strike the appropriate balance between achieving the public health and public safety goals. Whereas here the evidence indicates that a supervised injection site will decrease the risk of death and disease, and there is little or no evidence that will have a negative impact on public safety, the minister should generally grant an exception. So that came down in 2011. Stephen Harper lost the most recent election. Now there's a Liberal Prime Minister in Canada, and we're seeing more supervised injection facilities opening shortly in other cities across Canada. Research. I think whenever we're doing SIF research, we need to know some basics. Are people interested in using the facility? Would they be willing to use one? So I did a really small pilot study in Rhode Island. We interviewed 54 people, young adults who were using prescription opioids non-medically. 31 of those had reported injecting in the last 6 months. We very briefly told them about an SIF. We just said if there was a place where you could go, where you could inject your drugs without persecution and under the supervision of a nurse, would you be willing to use it? 80% said yes, and 100% of the people injecting daily said they'd be willing to use the facility. So, my goal is to try to do more of this kind of research to show that there is interest in the community for this kind of approach. And that's it. Thank you. So it sort of is a win-win. The population benefits, and they really are thankful for the and advocate strongly for the facility, and from a public health point of view, it's very effective as well.